Welcome to this week's Royal College of Pathologists webinar on the COVID epidemic. This week we're venturing further away from the microbiology to other branches of pathology, and we'll be discussing coagulation in COVID. I'm delighted to welcome Professor Beverley Hunt, who's a professor of thrombosis and haemostasis and works at Guy's and St Thomas's, and she's posing the question, what's up with coagulation? So if I hand over to Beverley and you take the screen, off you go.
Well, thank you very much for inviting me, and I'm going to whisk through what is happening in coagulation and what we think actually now on the 1st of July, because we seem to have come an awful long way. So I think that we had some misleading data, or the Chinese population have behaved differently with coagulation than European and North American patients. So we go back to this paper published in February. It's looking at the clinical characteristics of coronavirus as seen in China and Wuhan, and you will notice that these patients tended to be thrombocytopenic, and they had very high levels of D-dimers. And there was a correlation between the level of D-dimer and the disease severity. And this was really summarized in another paper by Zhu, and they showed that in COVID, there's lymphocytopenia, the platelet count tended to be low, raised LDH, raised TROP, prolonged prothrombin time in a significant number, and of course what we do know now, really high levels of acute phase proteins such as ferritin associated with raised levels of interleukin-6, and again at the bottom the raised D-dimers, particularly high in those that died. So this association between outcome and coagulation changes was most marked for the D-dimers, which, as we all know, are fibrin degradation products, and the prothrombin time. And if you look at the first papers, they actually said the patients had disseminated intravascular coagulation. So when the cases arrived in London, just to show you some of the data, so these are the patients days after admission, the PT becomes further and further prolonged, particularly in the non-survivors. We've got D-dimers rising, again much higher in the non-survivors in green than the survivors in blue. And here we've got fibrinogen. Now I just want you to note normal fibrinogen is 2 to 4 grams per litre, and we've got high levels of fibrinogen and that they plummet pre-morbidly. And just to fall back and remind you about the concepts of thrombosis and haemostasis, so the coagulation system developed as an effective system of the immune response. It is part of the innate immune response, and the whole point of it is to lay down fibrin around invading bugs and bacteria to entrap them so they can't disseminate. And then the other thing that I think we've forgotten is that the endpoint of inflammation is thrombosis. So looking typically at inflammatory diseases that I see, Behçet's and vasculitides, the endpoint, if you have profound inflammation, is microvascular thrombosis. And if we give them anticoagulants, it doesn't make them better. They need anti-inflammatory treatment. Lastly, we are dealing with patients with respiratory failure in severe COVID, and hypoxia will lead to induction of transcription factors that will lead to a prothrombotic state. So I don't know how you see COVID. For me, I see it entering the body, binding to the ACE2 receptors, which are all over the pulmonary epithelium, but we know also present on endothelium, monocytes, and adipocytes, and other tissues. Thankfully, the majority of patients get better after a short illness or can be even asymptomatic or have anosmia. And the problem is globally that we have a minority, and it's hard to know what percentage of a population that is. I think in the Brits it's probably higher because of our underlying comorbidities, is that patients develop COVID pneumonia. And they are developing a massive inflammatory response with the cytokine storm and macrophage activation. And those are the ones that we are seeing in hospital. And we describe them as moderate if they need oxygen, and severe if they need mechanical ventilation. And because we have this because we have this cytokine storm, we have a profound prothrombotic state. And for me, I think what's really interesting is all of the states that predispose to severe COVID, obesity, diabetes, cardiovascular disease are inflammatory states in themselves. And if we think about the adipocytes, they have ACE2 receptors on them. If you have a lot, you're producing much higher levels of cytokines. They also interfere with coagulation and also cause a prothrombotic state. So quite interesting, I think, and maybe we'll learn more about that as time goes on. So at Guy's and St Thomas's, we admit for oxygen. We have a traffic lights pathway. The more hypoxic the patients were, the more likely they were to be ventilated. If they weren't at a certain level of oxygen saturations, they were given supplementary oxygen on the wards. And so when we come to look at COVID pneumonia, as I'm sure you're all aware, there is profound inflammatory inflammation with lymphocytes and macrophages, and the hallmark of acute lung injury is extravascular fibrin deposition. We also have this cytokine storm, and these cytokines leading to these very high levels of ferritin, CRP, D-dimer, and fibrinogen. So we know from multiple studies that microvascular thrombi are present in areas of lung inflammation with COVID. So this has actually led to a problem in deciding what is going on if you were to look at a CT pulmonary angiogram in patients with COVID. So we were expecting that these patients had high rates of venous thromboembolism as described in China. They're activating all parts of Virchow's triad, very sticky blood. We know that COVID enters into the endothelium, causes endothelial cell activation, and we've got these patients immobile, so there'll be stasis of blood. But we're being caught out, I think, because we had forgotten that actually, if you have areas of high inflammation in the lung, you're going to have immunothrombosis present there, and that too can show up on a CTPA by having small areas such as segmental or subsegmental changes, blockages on CTPA. And what are the mechanisms of immunothrombosis? Well, we've got the very sticky blood and endothelial cell activation, monocyte activation. It just looks like the whole of the rest of the immune system with COVID, in that everything is switched on. So the endothelium is probably expressing tissue factor. We know that neutrophils are playing a major part by extruding their DNA, netosis, which the platelets also play a part in. So what has happened in COVID is that there has been this enormous awareness of finding a lot of clot on scans. So we've got quite a high rate of DVT when we do Doppler, and then a lot of patients have had CTPAs because they've become hypoxic suddenly, and they have found large vessel occlusion, but also these segmental and subsegmental lesions that we now think are probably due to immunothrombosis. So these are all the papers come from Europe and also from Wuhan, citing really high rates of VTE in those who are ventilated for severe COVID. At the bottom, we've got our paper, which we looked at the first 66 patients that went through our intensive care in March, and we took out all of those that just had segmental or subsegmental lesions on their CTPA, and we found we have a rate of VTE in that group just whilst they're on critical care of about 5%. The issue for these patients is that we're not clear what the bleeding rates are. Everyone says COVID doesn't bleed, but we found a 6% rate of major bleeding, but we did include patients on ECMO who we know bleed quite a lot. So just to show you some of the coagulation changes from our series, and there are many series out there, but I know this data so well, hey, you're going to see it. So here we've got Klaus fibrinogen at the top on the left, and you can see that the patients are running Klaus fibrinogen levels 7 or 8. No discrimination really between those who've had VTE and those who haven't. Next, on the right, we've got very high levels of D-dimer. You can see this is a logarithmic scale, slightly higher in those with VTE, but not discriminatory. And at the bottom, we've got procalcitonin, ferritin, and CLP, all very high. So this picture is one of acute inflammation. So what we did find was this is not DIC. The Chinese got it wrong because the PT and the APTT are near normal. You'd expect a low fibrinogen in DIC, and the platelet counts are also high normal. So it looks like that the main changes of coagulation are those of an inflammatory state, and until this paper came along and another one published in the New England Journal saying that antiphospholipid antibodies were common in these patients. Well, how badly reviewed was this paper? And this is a real problem, I think, for a lot of the coagulation papers early on. So they said these 3 patients have got antiphospholipid antibodies. It's from Wuhan. We don't have the antibody levels. They're only done on one occasion, and we don't know what the titers are. Now, we actually know that if you have an acute illness, you will get antiphospholipid antibodies around the time of the illness, and they will disappear. And we do not say patients have antiphospholipid antibodies until we've checked those patients 3 months apart. So these aren't antiphospholipid antibodies, they may just be an artifact of the illness. And the other problem was these 3 patients had such severe underlying comorbidities, they were liable to get thrombosis anyway. So coming to the D-dimers, these really high D-dimers that we thought we hadn't seen before, in Wuhan, they went back and they looked at patients from the previous years who had had viral pneumonias, and they look back at their D-dimer levels. They're in the second column, and you can see that they too have really high levels of D-dimers. So this may not be unique to COVID. And the reason that it's probably not unique to COVID is that the D-dimers are probably not just being produced by activation of coagulation. We know that if you produce thrombin, some of it will go to stimulate tissue plasminogen activator, release from the endothelium and activate fibrinolysis. But also in the lung, in acute lung injury, we know the pneumocytes themselves are capable of producing urokinase. And there's some evidence from SARS-infected mice that the more SARS these poor mice get, the higher the levels of urokinase being produced. And it's a response to all that extracellular fibrin deposition. It's got to be broken down and processed and healed. So we don't fully understand this pathway, but we suspect that a lot of the D-dimers or coming from the lungs themselves. It's not just the lungs, it's the macrophages too, because the macrophages can generate plasmin themselves. They produce urokinase, and they've got a neat little mechanism by which they can grab passing fibrin and ingest it, break it down with cathepsin, and then release D-dimers. And lastly, platelets. So it's the last 2 weeks that data on platelets has come through, and the platelets themselves can carry the virus. They don't have ACE2 receptors, but they can carry it around and disseminate it through the body, and they are very activated platelets, and they are producing inflammatory cytokines just to help with this cytokine storm. So platelets are probably immunomediators of this inflammatory state. So, to summarize, it's not as the Chinese thought. It is not DIC that we're saying. We're seeing an acute inflammatory response with really high levels of coagulation proteins, because IL-6 is telling the liver to produce vast amounts of these proteins. The D-dimers, which are really very high, probably spill over from acute lung injury. And actually, we've got a normal platelet count, PT and APTC, unless a patient is coming to the end of their lives and they have multiple organ failure, and then the hemostatic system will fail too. Clinically, we are seeing high rates of VTE. We're also seeing immunothrombosis, and I haven't had time to talk about myocardial infarction and the increased rates of stroke. So just to say, this extraordinary paper, again from Wuhan, looked at the patients in intensive care and gave some of them heparin. So those the heparin users are in red and the heparin non-users are in blue. Well, of course, for us in the UK, anybody on intensive care would automatically get a small dose of low molecular weight heparin as thromboprophylaxis. But this paper says if you use heparin, you have better survival. We don't know why they were put on heparin. We don't know what the dose of heparin was, or even which heparin, but this is the data we have so far. So we are all giving thromboprophylaxis to our patients. This is an action card from Guy's and St Thomas's telling them how to manage the patients hematologically. You remember we had to redeploy ward doctors onto critical care. They were on a very fast learning curve. Finally, there is research going forward into thromboprophylaxis in moderate and severe COVID. There's been a failure for any of the RCTs put forward to NIHR and the CMO to be agreed. So we just have some trials going forward on the big platforms. So REMAP-CAP is looking at critical care, and I'm involved with the newly started anticoagulation domain. We've got full dose low molecular weight heparin versus standard thromboprophylaxis in the patients. We've recruited about 70 patients at the end of last week, and at the moment we're building an antiplatelet domain. Thank you for listening.
That's a fantastic review of what is a fast-moving subject. I perceive a slight element of criticism of some of the manuscripts that are coming out during this pandemic, and I think it's not only in the field of haematology where the rush to get into print is bypassing perhaps more appropriate, thoughtful peer review. So you raise a number of issues. Can I start at the beginning with the China claim that they were seeing DIC? Have I interpreted you correctly in that you think it's not that the Chinese genuinely had a different response to this virus, it's that the Chinese physicians misinterpreted the data that they had?
So I think that they were tending to see patients towards the end of their lives much more frequently. They did have a high death rate. And there is a tendency, I think, for people to say things are DIC when they don't understand them. there is a International Society of Thrombosis and Haemostasis DIC score, and those patients didn't fulfill those criteria. And in some ways, it's been quite difficult to row back. When someone says, oh, this is what it is, we've been rowing back and we're saying, no, it's not that. It's they've got this amazing inflammatory state. Yes, of course, they get DIC at end of life.
Okay. And if we move to the pathology in the lungs, you showed some pictures and emphasized the excess fibrin deposition. Can I ask, is that something new, or is that just a generalized response that you see in a number of different inflammatory lung diseases?
So there's, okay, research from acute lung injury over the last 5 years has recognized that the hallmark is fibrin deposition extravascularly, so that's not new at all.
And I was thinking particularly of either H5N1 flu, which is associated with cytokine storm. So we're looking at a common pathway to severe lung damage rather than anything unique to this virus.
Yes.
Okay.
Except I think that the prothrombotic state's probably worse, and there's probably more immunothrombosis in these patients.
Right. So that's an interesting term, which I've not come across. Shows you how long ago I did my hematology. Immunothrombosis. Does that imply, is that entirely innate immunity, or does the adaptive immune response come into that, and might it be related to the appearance or non-appearance of specific antibodies and T cells?
So it's a consequence probably of the innate. And it's really cytokine driven. So, I mean, if you've got IL-1 or TNF, you will get upregulation of tissue factor. And the other thing is you've got endothelial cell activation, because you've got the virus within the cells, and they tend to puff up and separate, and you expose subendothelium where there is tissue factor, and that will drive local thrombosis.
Okay. You're describing changes in patients, and it sounds like the research that you've been doing is on patients in critical care. What happens in patients with mild disease, or do we just not know? I mean, just in simple terms of their clotting and platelet count.
So it's not my research. I sort of gathered together what the general feeling is. So we aren't aware that patients who have mild disease have these inflammatory changes. These inflammatory changes are a result of the lung disease.
Okay. And then as a consequence of improving understanding of what's going on, the obvious question is, what implications does that have for either prophylaxis or therapy? So you mentioned 1 or 2 trials that are going on, but I've got questions here about any data on prior aspirin use by patients and whether that impacts on disease severity. There's another question on if patients are on warfarin, does that impact on their pathology?
Okay, so internationally, there are randomized controlled trials of different doses of anticoagulation, and we haven't been able to start any in the UK, which is why we have put this arm on REMAP-CAP, and that is comparing full dose anticoagulation with standard thromboprophylaxis in the patients in critical care, and looking at rates of VTE and patient outcome.
Yeah, okay. I mean, that's very valuable to do. I guess the question is, how do you stop people ending up in critical care? And would it be, as soon as you diagnose someone, even if they're in primary care, let's say in the second wave, should a GP be thinking of starting some kind of anticoagulant therapy or prophylactic therapy, or is the evidence just not there?
So there is no evidence whatsoever. And we have to remember that the majority of patients will not have moderate or severe COVID. So there is also coming through, and I mean, I run a charity, and we're starting to get calls from people who in lockdown are quite immobile. and who aren't moving around and are having deep vein thrombosis and pulmonary emboli. So I think that there's that pathology going on. The other issue for us is we're sending people home from critical care who have been usually on a ventilator 20 days. It does take quite a while, and they've lost muscle bulk, and they're probably very immobile. So we're talking about giving them extended thromboprophylaxis for a couple of weeks until they've recovered a little bit more. And again, we need a trial, and a trial was put into NIHR and has been turned down.
Right, oh dear. A question, can you expand on the risks of bleeding? Have you seen intracranial hemorrhage?
So yes, we've seen intracranial hemorrhage. I don't think we've seen it any higher than in any other patient group, but that data needs to be gathered. We are at Guy's and St Thomas is a really big ECMO centre, and we do see a lot of intracranial bleeds anyway outside of COVID. And I'm not aware, we're just analysing the data, but it doesn't look like the rates are going to be any higher in the COVID patients.
Okay. This is a bit similar to the one I asked earlier. Is this virus fundamentally different from other viruses in its hematological impact?
So I also work on Ebola and Congo-Crimean hemorrhagic fever and Lassa, and the answer is yes. I mean, in those conditions, we're getting a bleeding problem. Here, we've got a profound thrombotic problem, making it fairly unique.
So do you want to speculate on the different pathogenesis?
If you look at the viral hemorrhagic fevers, they produce glycoproteins. They use the local cellular mechanisms to produce glycoproteins, and I suspect that those glycoproteins are acting as platelet inhibitors very early on in the illness, and actually that is the subject of my research.
And I think with Ebola, there's evidence that it actually infects the endothelial cells. Is that also the case with SARS-CoV-2?
It does. And there's also a lot of data suggesting that those patients have DIC, but actually when you look closely at them, they don't. So I'm just hopefully about to publish about that.
A couple of questions about long-term complications, which I guess everyone's thoughts are turning to now. Are you seeing unexpected thrombotic events a month or more after COVID-19? They've said specifically in non-hospitalized cases in young people, but I guess the same question would be in survivors who've gone home having been very ill.
So we know with hospital-associated thrombosis, which is what we're describing with venous thromboembolism in hospital, that the bulk of them, 60% of them, will occur post-discharge. And the definition of hospital-associated thrombosis is thrombosis during admission and for up to 90 days afterwards. It peaks at about 2 weeks afterwards and then falls off with a long tail until 90 days out. Yes, there are people out there and people who were in care homes who didn't get admitted to hospital, or people who refused to go to hospital who are now recovering. And actually, I'm going to see one of them tomorrow who's had a DVT 3 or 4 weeks out after having had COVID pneumonia, I presume, at home.
So that creates a bit of an ethical difficulty then. If these events are going to occur mostly after the patients go home, clearly you mentioned you're putting these patients on who've been in intensive care on long-term prophylaxis, but we just don't have the data, and we're not doing a trial to see whether that ought to happen to any patient who was hospitalized, even if they didn't end up on a ventilator or in intensive care.
So we have a lot of clinical trials looking at extended thromboprophylaxis after discharge in medical patients and critical care patients, and it's really only we've recognized the really high risk ones, which include those with very high D dimers, and who are old or have underlying cancer or previous VT that probably would benefit from extended thromboprophylaxis. But we haven't really looked at this amazing prothrombotic state before, so a trial would be desperately needed. And I'm not aware of any globally. And it's very sad, our very multidisciplinary, we had statistics, cost efficacy, we were going to randomize a couple of thousand patients, trial was not accepted by NIHR.
Oh dear. That does lead on to the next question, and I know from experience that there are people in the audience who've had COVID and recovered, and this question is obviously of great interest to them, is are there any markers at the acute stage which predict who might be in trouble later?
What, with thrombotic problems?
Yeah.
No. So, I mean, if you looked at the data we have, those who have had VT have had slightly higher levels of D-dimer as a group, but it's not discriminatory. There's huge crossover. And I think it's also, but we have to remember Virchow's triad, so we must try and keep these patients mobilizing, staying hydrated, and hopefully that will help.
Okay. So whoever's asked this question has said, I didn't understand. So he may have got it wrong, or she. It was said earlier in the presentation that anticoagulants wouldn't help, but later on there was a suggestion that the heparin improved outcomes.
So what I was talking about was the immunothrombosis. So the immunothrombosis is being driven by the inflammatory state in the same way as patients with Behçet's or a pulmonary vasculitis will thrombose within inflammation. And for me, and I think most of us, we feel we need to use anti-inflammatories to reduce the inflammatory stimulus, then you're less likely to get a thrombosis. The data from China showed that if they used heparin, because they clearly do not use thromboprophylaxis, though that's the global practice, they're not using it in critical care, they had a better outcome. So, but we don't know what dose they used.
Right.
It's very crude data.
Okay. And so the good news story about dexamethasone, is that?
I think it's fantastic. Yes, because it's going to reduce inflammatory state, I hope. And I've been talking to someone to persuade them to look at the rates of immunothrombosis in the two groups.
So yeah, how do you diagnose immunothrombosis then in life?
So it's very difficult. What we mean by that is that we're seeing patients, normally when you look at hospital-associated thrombosis, VTE, you would expect 2/3 of the patients have DVT and 1/3 have pulmonary embolism. When we look at the data from the COVID patients, the majority of them have chest symptoms. They had a very low threshold for doing CTPA. And so the bulk of them have changes on CTPA, and the bulk of the changes that they are seeing are just segmental or subsegmental changes without then going back to look at the legs, not finding any residual DVT there, suggesting those are probably immunothrombosis, but we don't have any other discriminatory way of looking at it.
So essentially it relies on the sensitivity of a pulmonary CT scan.
Yes.
Yeah. Okay. And is that become a routine investigation or?
So there, for us, there's a very low threshold of going there. Some of them will also give you some information about blood flow in areas of the lung, and I think that might be a way forward in helping us discriminate what might be immunothrombosis and what might be a true pulmonary embolism.
Okay, we're getting towards the end. I've got a very specific question. Are NSAIDs effective against immunothrombosis?
I don't know. No, we don't know, do we? I mean, we have to remember that the research that's being done in the UK is very limited, and we're at a very early stage of research. So no one has got any answers yet,
Okay.
apart from dexamethasone.
Right. Well, maybe that's an exciting note to leave it on. That essentially we've learned a huge amount in the 3 or 4 months that we've all been living through this, and clearly there needs to be there's a lot left to learn. I suppose we don't really want the second wave, but if it comes, you'd have to hope that we're ready to exploit a new load of patients to learn even more about this virus and its effects. So I think I've gone through all the questions. Thank you very much to the audience for sending those in. And thank you again to Beverley. That's been a fantastically educational session for me, and I'm sure for everyone. And very clear about what you do know and what you don't know, and how we might learn those things out.